Hi everyone, my name is Tara and I am here to present a case study on Mr. Justin Steady. Justin is a 29-year-old African American male. He was living at home with his parents and they found him down in the basement unresponsive with fecal incontinence. EMS was called. They tried Narcan twice given the patient's history of substance abuse but had no response. On assessment, they noted left gaze deviation and left-sided weakness, so they activated the stroke team at the hospital. Upon arrival to the ED, the patient had a witness seizure, for which he received Ativan and was stabilized, and then was taken to the CT scanner. Before getting his scan, however, he had an acute respiratory decompensation that required intubation. He then received a CT of the head, which showed a large right MCA stroke. Neurocritical care rated his NIH at 33. He also had a CT of his abdomen that showed left renal pole, splenic, and liver infarcts. He was sent to the ICU, and when he was hooked up on tele in the ICU, he was found to have ST elevation. Troponins were sent, and the cardiology fellow was consulted. Troponin came back at 13,400, and the cardiology fellow confirmed that the patient was in fact having a STEMI. He then did an echo at the bedside, which showed vegetations on the aortic valve. Infective endocarditis is now the suspected cause of the CVA, the STEMI, and all of the infarcts. Moving ahead to today, this is ICU day 4. The patient remains intubated and sedated. The NP was called to the bedside today by the RN for a change in the patient's condition. He is now tachycardic, tachypnic on the ventilator, and requiring increased ventilatory support. He's hypotensive at 98/41. His urine output has dropped to 15 cc's per hour for the last 3 hours, and his intra-abdominal pressure on the catheter reading is 18 millimeters of mercury. The NP does a physical assessment, which finds for neuro, he remains sedated. He still has the left gaze deviation and left-sided weakness, and there's been no acute changes in his neuro status. For the head and neck, he remains intubated. The left gaze deviation, a new finding is that his sclera is now yellow in both eyes. For respiratory, he's noted to be tachypnic to 28. Rhonchi were present both before and after suctioning. For cardiac, a diastolic murmur was noted. It's been present since admission, and he's tachycardic to 128. It was sinus tach on the monitor. For peripheral vascular, we noted new bilateral lower extremity edema, +2 pitting, and an elevated jugular venous pressure. For gastrointestinal, also new finding was a tense distended abdomen. Bowel sounds were hyperactive, and liquid stool was present in the rectal tube. The patient has been having liquid stool for approximately 1 day. For GU, urine, which was previously a light yellow color, was now tea-colored in the Foley bag, and oliguria. For integumentary, skin is cool to touch, which is a new finding. Findings we were already aware of were wounds to the bilateral wrists, which were present on admission, and scattered bruising. For psych, the patient is sedated and couldn't be assessed. As far as past medical history for this patient, there's not much. The parents were at bedside providing information. He was living at home with his parents, as I mentioned, prior to admission. He does have several years history of polysubstance abuse, including IV drug use. He was positive for methamphetamine and fentanyl on admission. Prior to admission, he had complained of chills, fatigue, malaise, and cough for approximately 1 week. He is on no home medications, no dietary restrictions. His BMI is 25, so his nutritional status seems appropriate. The patient socially does have an estranged wife. They have been separated for several years. They do have 2 children who are both healthy. Family history of hypertension and hyperlipidemia in his father, mother with no medical issues, and healthy pregnancies. Palliative care has been involved, has talked to the wife that is estranged. She deferred decision-making to the parents. The parents are still confirming that they would like full code status for the patient, despite multiple specialty doctors letting them know that he was unlikely to recover. Objective findings, we did a 12-lead ECG. It showed sinus tachycardia with no new ST changes. Vital signs, temperature is 37.3, heart rate 128, respiratory rate 28, SpO2 of 95%, and blood pressure 98/41 with a MAP of 60. The vent settings have a rate of 16, tidal volume of 450, FiO2 is at 100%, which is new, it was much lower, and PEEP is now at 8 centimeters of water. His IAP on the bladder catheter is 18 millimeters of mercury. It was previously 6. It has been 18 now for 2 hours. His urine output, which was previously about 35 cc's per hour, has dropped to 15 for the last 3 hours. Lab work is quite remarkable. Some of these findings are new findings, and some of them were already there. I did highlight with an underline the new findings. White blood cells are 25.2. They have been pretty steady at that range, not really rising much. Hemoglobin 10.3. Platelets are down to 87. They were 120. Creatinine is up to 2.9, which is an increase from 2.0 earlier in the morning. The BUN is up to 65. His liver function tests are very elevated. His AST is 255, ALT 134, and alk phos is 228. Billy is 2.4. Lactic acid came back at 2.3, was previously 1.8. INR is 2.4. CK 1173 was on admission, and troponin 13,400 also on admission. Done just now, ABGs showed a pH of 7.23, a CO2 of 27.4, and HCO3 of 18.5. And urine tox, as I mentioned, had been positive for methamphetamine on admission. Imaging results, these are new from immediately upon the patient's changing condition. Chest x-ray showed bilateral lower lobe infiltrates. CTA was negative for PE, but re-demonstrated the bilateral infiltrates. The CT of the abdomen is the original abdomen, showed the renal pole infarct, multiple splenic infarcts, and liver infarcts. The new CT shows ascites as well. CT of the head was done when the patient was first admitted, showed the large right MCA infarct and severe hypoperfusion to that territory. There were no new changes on the CT just now. And the echo previously showed aortic valve vegetation, and nothing was new since then. So my questions for you now. What is your differential diagnosis for the change in the patient's condition? What findings would make your most likely diagnosis? What would you use to support that? The next one, what further labs or imaging would you like to get for this patient? Number 4, what would you place these orders for the labs and imaging stat or routine? What initial orders would you place while waiting on testing? And finally, what do you suspect the outcome will be for this patient?